Well, welcome to the first pharmacology lecture in the pharmacology series for the advanced pharmacotherapeutics course. This lecture covers pharmacokinetics, which is essential to all topics in pharmacology and basically is the foundation of all the pharmacokinetic principles and the foundation of clinical therapeutics. Basically, it's all about drug delivery, ensuring that the optimal concentration of the drug ultimately reaches the target organ or the receptor site. While absorption, distribution, metabolism, and elimination, or ADME, are the integral components of pharmacokinetics, they may also serve as obstacles to drug delivery, particularly in situations where you have underlying gastrointestinal pathophysiology, for example, peptic ulcer disease. For practitioners as physician assistants, physicians, pharmacists, and nurse practitioners, it is absolutely essential that you have a complete understanding of the pharmacokinetic and pharmacodynamic principles that basically determine the final drug action, and once you understand this, you will be able to minimize toxicity and maximize therapeutic benefit. The pharmacokinetic principles basically integrates absorption, distribution, metabolism, and elimination or excretion, and therefore determines the final concentration of the drug at the receptor site. Pharmacodynamics, on the other hand, determines intracellular signaling, which then determines the final clinical efficacy of a drug. At the end of the day, an intensity and duration of action of any drug depends on how long it spends at the receptor. And this sustained pharmacological effect is absolutely dependent on the steady state concentrations of the drug. As a result, at the end of the day, pharmacokinetics is like a mathematical equation. It's a dynamic equilibrium between absorption and distribution and metabolism and elimination. The basic principles in ADME is important to understand in order to be able to understand the final clinical efficacy of a drug. The highest yield from ADME is actually distribution, metabolism, and elimination or excretion of the drug. Absorption basically determines the delivery of drug to its target organ from within the bloodstream or the systemic circulation. Distribution often is referred to as translocation of the drug or filling the body compartment with the drugs. During this time, an important interaction happens with plasma protein binding, namely albumin. Biotransformation, absolutely important, is entirely dependent pretty much on hepatic function and the complex reactions that happen within the liver, mainly to make the drug ionized, water soluble, and non-toxic. Excretion of the drug is pretty much dependent on the renal system, and therefore we need to understand which drugs are contraindicated in renal compromise and which drugs need to be basically require a dosage reduction in renal compromise. And once the drug reaches its target organ, it basically binds to the receptor and will ultimately bring about its final effect via intracellular signaling. So at the end of the day, pharmacokinetics basically is dependent on drug absorption, distribution, metabolism, and elimination or excretion. The dose of the drug that's administered does not always reflect the final dose of the drug at the receptor site, particularly if it's orally administered, because it may be broken down by gastric juices and by hepatic metabolism. The final concentration of the drug at the receptor site or at the target organ is what basically determines the ultimate pharmacological response or the clinical response. Understanding pharmacotherapy for all practitioners requires understanding the pharmaceutical process. Is the drug getting into the patient? Compliance issues. Is the drug getting to its site of action? Underlying pathophysiology may impede this process. Is the drug producing pharmacological effects? Receptor downregulation, mutations, and desensitization may actually stop the effects of a drug. And are you getting therapeutic success? Is the pharmacological effect being translated into a therapeutic effect? Is the patient getting better? As practitioners, you must understand which drug group should you use, which specific drug, what is the dosage, and what is the regimen or frequency of administration. If one does not understand the individual pharmacokinetic profiles of drugs, then this becomes an extremely difficult task to achieve. You have to take into account patient variables, which means patient variables may have underlying pathophysiology. You have pediatric and geriatric patients. Pediatric patients have limited binding capability. They have limited hepatic biotransformation. The problem with geriatric patients is they may have multiple conditions, hence would practice polypharmacy. They may have renal or hepatic compromise, and often in geriatric patients you have other complications such as hypertension and diabetes. Multiple drugs or polypharmacy also runs the risk of drug interactions, and the more polypharmacy there is, the higher the risk is of drug interactions. And underlying pathological conditions, namely peptic ulcer disease, other gastrointestinal disorders, renal dysfunction particularly, and also hepatic dysfunction, will cause problems as far as drug biotransformation and excretion is concerned. On your part, rational drug prescribing requires an accurate diagnosis, understanding the pathophysiology of the disease, understanding basic pharmacology and pharmacokinetics of drugs, and then transferring all of these into effective bedside action. Pharmacology is not about memorizing drugs. It is about understanding the pathophysiology of disease and then linking that to the objectives of treatment. Once you understand the objectives of treatment, you are in a better position to understand which drugs, why, and how often. So there are various routes of drug administration, and basically the fastest route of getting a drug to the target organ is via intravenous administration. On this slide you're seeing the various routes of drug administration versus the plasma drug concentration versus time. IV allows for the quickest and the most rapid transfer of drugs, followed by intramuscular. Subcutaneous and oral bioavailability is the lowest, simply because it has to traverse the gastrointestinal tract and the liver. So apart from this, you have rectal routes of drug administration via the skin using transdermal patches, lotions or creams, and of course you can also give drugs via inhalation or via the nose, and also intramuscularly and rectally. The advantage of IV administration is that the drug immediately enters the circulation, very quickly gets distributed to tissues. You get an absolute immediate response, and particularly it's not destroyed by gastric juices of the low gastric pH. Drugs such as penicillins, for example, are very rapidly destroyed by the low gastric pH. You can maintain a titrated and constant blood level. You can continue to administer large quantities for a time, and particularly for patients who are unconscious, IV route is always available. The disadvantages of IV administration is that once it's there, it's there. You cannot remove it, and it can be particularly dangerous and toxic for those drugs that have a very low therapeutic index or have high toxicity. If an injection is given way too rapidly, you can cause injection site reactions or run the risk of allergic reactions and anaphylactic shock. Sterile technique must always be used, and of course there is some degree of discomfort, and local injection site reactions and irritation may happen. A few important terms. First, drug bioavailability. The definition of drug bioavailability is the amount of unchanged drug that reaches the target tissue. The important word here is unchanged. Therefore, bioavailability is close to 100% if the drug is given intravenously, because it goes straight into the systemic circulation. If the drug is given orally, you run a very high risk of reducing the bioavailability significantly, because it will enter the hepatic circulation, undergo first pass hepatic metabolism, and then ultimately see the target tissue. And some drugs are significantly metabolized and may have a bioavailability lower than 50%. So first pass hepatic metabolism is what influences bioavailability. After a drug is orally given, it will undergo first pass hepatic metabolism prior to reaching the systemic circulation and the target organ, which basically means that the final concentration of the drug will be reduced. For example, propranolol, the beta blocker, undergoes extensive first pass hepatic metabolism, and its bioavailability is reduced by at least 50%. So essentially, IV administration allows for direct administration of the drug into the systemic circulation, whereas if you gave it orally, it will have to go through the hepatic circulation first prior to reaching the systemic circulation. Other factors that affect bioavailability and solubility is lipid solubility. Most drugs basically are lipid soluble, have a low molecular weight, and therefore will readily go across the lipid bilayer membrane. Some drugs are extremely unstable and will break down in the low gastric pH, particularly the penicillins. Next is the molecular size or the particle size. The lower the size, the lower the molecular weight, the more readily it will be absorbed and will have a higher availability. So we often compare the bioavailability by comparing the area under the curve after a drug is given orally divided by area under the curve after it is given intravenously. Naturally, after a drug is given intravenously, you will have close to 100% availability. Bioavailability varies with different routes, IV being the highest, and oral and rectal and inhalation being on the lower end. Oral particularly depending on how much of the drug basically gets metabolized by biotransformation. Transdermal patches are often used particularly for pain or relieving pain, and they usually have anywhere from 80 to under 100% bioavailability. Transdermal patches are slowly absorbed over the skin over time.